mindful of others' time. So let me share my screen. Yeah, thank you very much for accepting our invitation this evening. This evening, I know it's time is precious, especially on a weekend, to be available to attend a meeting at 8 in the evening. So it's challenging. So we called you because because you were involved in teaching non-technical skills various participants, either to University of Rwanda or in the district hospitals, through the project that was implemented by the Rwanda Surgical Society about essential surgical skills training and non-technical skills. So the aim of this meeting, we want to expand from where we left. We taught the non-technical skills to multiple people from district hospitals. And one of the questions or the ask we got was to expand the NOTS training. And so we are finding ways how we can do that. And one way that multiple people mentioned is to integrate the NOTS training program into the new employees orientation program, because most of the hospitals have orientation week to new employees. So they thought that could be a good opportunity to teach the non-technical skills as well. So in this perspective, we are conducting this evening, this session it's about a refresher on the non-technical skills, and also to describe how we are going to collect the data on the hospitals, from the hospitals, how is it possible to implement the NOTS training at their hospitals, mainly through the new employees orientation program. So I think Christophe will introduce, we have a new person here, so Christophe will introduce him, and then I will talk about this project and present some slides that we will use during the workshop. And Christophe will provide the description of how this project will be implemented. So in general, we are planning to visit about 12 hospitals, and we will present the notes during the meetings, and then after the meetings, we will administer the survey about the hospital readiness to implement a notes training program. And then Dr. Innocent Kisima will describe the tool that we will use to collect data from the district hospitals. So if there's no other question, please, Christophe, the floor is yours.
Okay. Thank you, Ajit, for this platform for discussing about the coming project, and thank you everyone for joining this session. As you said, we have conducted NOTS course to different hospitals in a few years back, and this is a time to see whether the courses we have given has had impact. And immediately, short time after introducing this course, some feedback from the participants was that they wished we keep after training more health personnel in different hospitals. And we think that this coming course will help us to really see how we can integrate this course into the regular practice in the different hospitals. I'm pleased to welcome everyone for this session, and we have Innocent is a student from Tanzania, and he has been involved in such in the same training, and he is collaborating with a team from Harvard University, and they have used the SORT tool to collect data in regards to NOTS course. So he will be with us, and he will help us to introduce and show us how is the data collection form, and so that we become familiar with it. And it is more different from a little bit different from the tool we have been using to assess the cost impact. But this one is a new tool. We'll be trained about it so that we become familiar with it. Without taking much time, I really thank everyone for joining this course and look forward to Fleet for deliberation from this course. Thank you.
Yeah, thank you very much, Christoph. And let me share my screen. So these are the slides we've been using while teaching the non-technical skills for surgery in variable resource context in district hospitals. So we make some modifications, but the content is the same. So we are planning to, while visiting the hospitals, to make about 45 minutes presentation to all the people we will be able to get. And then after the presentation about the non-technical skills, how the non-technical skills has been taught in Rwanda, and what we think would be the next steps, and then ask them to provide, to take a survey about the hospital readiness in implementing a NODES program. So I think basically these are the slides you will be using while visiting the hospitals. I'm going to go through them as a way for us to remind ourselves about the non-technical skills, and then maybe some later on we'll practice them before giving them. So we expect that by the end of the presentation, participants will be able to define the non-technical skills major categories and elements, and to describe the role of the non-technical skills on patient safety. The NODES training program is a result of a partnership between multiple institutions from Rwanda, from the US, and from the UK. So in our daily life, we encounter surgeons and anesthetists and perioperative nurse, and we want to become as good as them or better than them. And we ask ourselves, like, what does it take to become a better surgeon, or a better anesthetist, or a better nurse, scrub nurse, or what does it take for us together to become a better team? There are skills that we have to be able to perform, or a number of behaviors that we have to be able to demonstrate to become a good surgeons or good teams. These include, like, you have to be able to perform the goal of the operation while minimizing the complication. For example, you have to be able to perform a cesarean sections while preventing uterine rupture or minimizing pain. These skills can be divided into technical skills, such as careful handling of tissues, appropriate airway management, accurate instrument count. They can also be categorized into the non-technical skills, like planning ahead, respond to challenges, or create a supportive environment, or anticipate materials needed for the operation. So the non-technical skills were defined as social and cognitive skills that complement medical knowledge, appropriate use of equipment. And the non-technical skills were developed because almost 50% of the intraoperative errors are related to breakdown on communication or other non-technical skills. The analysis of adverse events revealed that in half of the time, the information is not fully transmitted. And while conducting cholecystectomies, the analysis found only 3% of common bile duct injuries are due to technical performance, while the 97% of the time, the common bile duct injuries are due to errors in perception. And studies have found that technical errors are strongly associated with team situational awareness. So the non-technical skills have been identified important as in other high-risk industries, for example, aviation, nuclear power, or offshore drilling. And the non-technical skills is the concept that initially was developed in the aviation industry and then later was translated to healthcare. Despite the current development in teaching surgical skills and availability of advanced equipment, we still encounter challenges. For example, surgeons conducting wrong site surgeries or operating on wrong patients. And however, these errors are completely preventable. For example, in the US, the wrong site surgeries occur between 1,000, 2,000 times a year. As a way to prevent this, the World Health Organization has adopted the surgical safety checklist, and it is widely used across the globe. And it was found that the use of the surgical safety checklist is associated with 50% reduction in mortality and 36% reduction in post-operative complication. However, despite this, the evidence that the surgical safety checklist is effective, only 30% of providers from low and middle-income countries use the surgical safety checklist. And the use of the surgical safety checklist requires a teamwork and continuous training. Some of the reason why the surgical safety checklist is not used is that there's insufficient enforcement by the hospitals administrators. In some cultures, the nurses are not empowered enough to speak up or enforce the surgical safety checklist. And especially in low and middle income countries, the rate of emergency or rush cases prevent the use of surgical safety checklist. Another barrier is that the checklist is available in only 6 languages, which may limit the understanding and the use of the checklist. And the use requires a culture of teamwork because it is not only something that one person has to do, it requires the entire team, the surgeon, the anesthetist, and the nurse to work together to implement the surgical safety checklist. So we are going to watch a video. This is a simulation-based video. However, it reflects the situations that we observe in our daily life in the operating room. Are you able to hear the voice?
No, we are not hearing the voice, but you can see only the image.
Okay, how about now?
Personally, I'm not hearing nothing.
Okay, let me change.
My senior is late, about 30 minutes. I think we can start if you join us.
How about now? Do you hear the video, the voice?
Yes.
Okay.
We do.
Okay,
Yes.
thank you.
Okay, time out.
Yes.
I'm Juliet, I'm circulating nurse.
I'm Christoph, I'm a resident.
Joseph, anesthesiologist.
Our patient is 64 years, a male patient who has peritonitis on gastric perforation. We are planning to do laparotomy and Omanto patch repair. The surgery will take 1 hour. Do you have any concern, Violet?
No concern.
Did you give a prophylactic antibiotics?
Yes, ceftriaxone 2 gram given.
Good. Any other concern?
Yeah, I have a concern. Our patient is cachectic. There is a history of weight loss, and he is anemic. I think there is something going on.
Oh, no, there's nothing wrong. Just a simple surgery to take like 1 hour and we will be finished. And but I think my senior, when he's around, he will classify that. But I think there is no worry about the surgery itself.
Hi Tim, how are you?
Hello, sir. We're waiting for you.
Yes, I'm here.
Yes.
Can we start?
Yes, sir.
Yes.
Yeah. The scarf is ready.
Doctor,
Yes, please.
I have a concern.
Yes.
Our patient has weight loss.
Mm-hmm.
He's cachectic,
Yes.
and there is weight loss.
No worry. This will be a quick surgery, like the one we did last week. We just find the perforation, repair it, and then we are out. Don't worry.
Okay. If
let's
you are
start.
comfortable, we can proceed.
Yes, we are more than comfortable. Let's start. Incision.
12-30 incision.
Yes, action. Yes, Christoph, do you see a lot of air in the peritoneal
yes,
cavity?
yes, it is getting out.
Yes, a lot of fluid, gastric juice in the abdomen. So let's find the perforation. It is usually up here. Do you see where the fluid is coming from?
Yes, I see.
That's where the perforation is coming. So now that you find the perforation, prepare the momentum to patch, then I'll get the switch.
Prepare it.
20 Vicryl.
Yes. Preparing omatum is already. I finished to prepare the omatum.
Yes.
But excuse sir, I'm hearing something wrong. There is a mass.
No worry, that's just a demand. This patient, they have demand. Let me feel it first. Oh my God, there is a tumor.
Is there a tumor?
Yeah, there is a tumor, but let me explore very well from the posterior. It's even bleeding.
Can we do deeper?
Blood pad, please.
Yes, here it is. Yes.
I can't see even where the bleeding is coming from.
Yes.
Bring this back.
Yes.
Yes. Violet,
Yes,
do you know if we have blood for this patient? Can you get the ICU bed? Definitely, this patient needs an ICU bed.
an ICU bed.
Yes.
You call me ICU.
Yes, call the ICU, please.
ICU,
Our patient is having tachycardia. I'm giving fluid.
we have a bed. We have a patient. Do you have a bed? Oh, there is no bed.
What?
There is no bed.
No bed?
No bed.
In the entire hospital, no bed? That's very bad. So, you see, Christoph, there's a lot of bleeding, and I even don't know where the bleeding is coming from. So usually, this patient, yeah. Can you get the blood, Violet?
Let me call in the laboratory if they.
So do you see, Christoph, this patient is hypertensive, cachectic.
Is
So,
very innocent blood
Usually the tumor seems
because
to
we
be
are
resectable.
operating
So he
room.
needs a
We
resection.
need it.
But
I'm having unstable
we're
BP.
not prepared.
Doctor,
Let me bring.
I'm having a low BP. I'm giving fluid.
So please keep giving and yes.
You have to send the sample.
Yes, send the sample please, and so we need to keep packing while we're getting the blood and get the ICU bed. Keep checking if we get an ICU bed. Yeah. Keep packing, please.
Yeah, thank you very much for watching. So, wait. Depending on how much time you will have during the meeting, you may ask participants the examples of what they observed. If you don't have much time, you can describe like the surgeon arrived late and is rushed. Surgeon dismisses information from the anesthetist, and the surgeon fails to consider consequences of manipulating the tumor, and it didn't help the team anticipate consequences of major resection. For example, the anesthetist has not completed blood typing and pre-op lab tests, and he didn't communicate a change in the plans to the scrub technician. So the notes was developed because there was lack of valid and reliable tool to measure the non-technical skills. And the goal of the non-technical skills tool was to develop a system for surgical teams to teach, observe, and evaluate and provide feedback based on real-time behaviors in the OR. The non-technical skills has 4 categories. We have situation awareness, decision-making, communication and teamwork, and leadership. Situation awareness has 3 elements about gathering information, understanding information, and projecting and anticipate future states. Based on the notes definition, the situation awareness can be defined as developing and maintaining a dynamic awareness of the situation based on collecting information from the environment, either from the patient, for example, the vital signs of the patient. For example, the blood loss, collecting information from the team, who is available, what other members or other skills you need from the team, collecting information from the time and from the equipment. Then from collecting information, you have to understand what that formation means and think about, given that situation, what may happen next, and then start preparing about managing the situation if anything bad happens as a result of the current situation. The second category is decision-making, which also has 3 elements, considering options, select and communicating options, and implementing and reviewing options. And decision-making can be defined as skills of diagnosing the situation and reaching to a judgment in order to choose an appropriate course of action. So for decision-making, you have to, given the situation you are in, consider possible options of action you may take to improve the situation, and then communicate that option to the members of the team so that everyone is aware of what is happening, and then implement the actions you selected and continue evaluating if the actions you are implementing are leading to an expected outcome. And if the chosen actions don't lead to an expected outcome, you have to select another action and continue evaluating if the actions are leading to the expected outcome. The third category is communication and teamwork, which is about exchanging information so that we create a shared understanding, which means that everybody on the team is aware, has the same understanding about the situation, and then coordinate the team activities. And communication and teamwork can be defined as skills for working in a team to ensure that the team has an acceptable information in a timely manner to aid establishment of the shared understanding among members of the team. The fourth category is leadership, which has 3 elements like establishing and maintaining standards, supporting others, and coping with the pressure. And leadership is defined as leading the team and providing direction, demonstrating high standards of clinical practice, and being considerate about the needs of individual team members. The non-technical skills has also the rating tool, which is a tool that is used to observe the surgeon in the operating room, or you can also use to observe other members of the team in the operating room and then rate them on their behaviors. So the rating can be done either at the level of the categories or at the level of the elements. So the rating ranges from 1, which is highly ineffective, up to 4, which is highly effective. And you can document examples of behaviors you observed so that you can be able to give the feedback to the person you observed after the case. So the non-technical skills that was developed in high income settings is it applicable to low and middle income settings? Because other every settings or every environment have their own challenges. However, the non-technical skills has been found to be able to address the challenges either from the high income settings or from the low income settings. That's the reason why the non-technical skills for variable resource context was created and adapted to address the challenges specific to low and middle income countries. So this image displays the process of developing the notes addressing the variable resource context, which started from a systematic review, interviews with surgical providers, surgical team providers from Rwanda, and then they found that there was a difference in variability, which means that today you have an equipment that is working properly, and the next time you need that equipment, either it is not available or it is not working. And then we created relevant videos reflecting the current practice, the environment we work in, and the disease, the type of disease that we manage. And then from there, a curriculum addressing the variable resource context was developed. And it was taught to participants from the University of Rwanda, from Kigali University Teaching Hospitals, and from district and provincial hospitals. So this some of the images of the notes training to trainees from the University of Rwanda and Kigali University Teaching Hospitals. And here we have the image of one of the notes training program to participants from district and provincial hospitals, where we taught them notes in the classroom and also technical skills in the operating room. So what happened after teaching the notes course? Our team conducted post-course interviews and visits to people who took part of the course to understand how they implemented the non-technical skills, what challenges they face while implementing non-technical skills, and how they can be supported to translate the non-technical skills in their clinical practice. So what we learned from the participants is that the notes course helped them provide safe patient care, either preventing errors. For example, one gynecology resident said that he was about to leave 2 gauzes in the abdomen, and the nurse came and spoke up, and then they were able to identify the gauzes that were missing. There is also adherence to the surgical safety checklist, where one resident said that after taking the notes course, he started applying the surgical safety checklist and invited other people to join him in applying or doing the surgical safety checklist. There's also prevention of wrong site surgery, where a resident described like before the operation, the surgeon was about to conduct surgery on the wrong leg or wrong limb, and then after checking on if the site was marked, they found that they were about to amputate the wrong limb, and then they changed the plan. Some of the recommendations we got is about training more healthcare providers. Like people say, like when you work with people who took the course, they know exactly the importance of the non-technical skills and they adhere to the non-technical skill practice. However, the participants suggested that we expand the course by increasing the number of days or reaching to more participants. So it is in this perspective that we are planning to integrate the notes training into new employees orientation programs at your hospital. And we want to hear your perceptions on how this program may work at your hospital. So please take this survey and answer the questions and help us understand how we can integrate notes training program into the new employee orientation training at your hospital. So after this, we will ask them to we'll give them opportunity to ask questions and then hear their thoughts. So I would like to hear your thoughts or feedback, or if you have any question. So it probably took me 40 minutes to go over the slides. So I think it will require practice for the people who will represent this in the upcoming days. And if you found anything that is not understandable or that needs to change, please let us know. So we will share these slides and feel free to modify them as you see fit, as long as we keep the core message. Thank you. Any question, comment?
Thank you, Dr. Gide, for remembering this important course. I think the perspective you are getting in is very important. Since you had this course, I think some of us have already forgotten these habits. But while we were doing this course, it was very nice, and I think it saves many deaths from patient. So if we resume this and we integrate it in the program, I think it will be more effective and helpful. Thank you very much.
Yeah, thank you very much, Dr. Joel. Yeah, you are right. So it has been a while since we taught this course, and if every knowledge, if it is not used or practiced, we tend to forget. So that's the reason why we thought it would be good if we can find a way of integrating this into the routine practice or training at the hospitals that we visited.
Yes.
Yeah, thank you. So next, I would like to, is there maybe as people who participated in this course or who taught the course, and is there other opportunities for teaching the notes course that we can explore apart from integrating it into the new employees orientation program?
Thank you. I think it can also be integrated into the training at the university courses for postgraduate and for students in the master's program for perioperative nursing. It can be integrated into as they can also help in propagating the message. Thank you.
Yeah, thank you very much, Vilbe. I think that's a great point. So we'll keep advocating to UR to see if we can officially integrate the notes into the curriculum. Yeah. So next, I'd like to invite Dr. Innocent Kisima, to share his experience in using the SWOT tool in assessing hospital readiness to implementing a new intervention.
Thank you, Dr. Ejid. Hello, everyone.
Hello.
Can you see my screen?
Yes.
Yes, yes.
Okay, so I'm Dr. Innocent, as Dr. Ejid introduced me. And today I would like to take you through what the SWOT is and how the process of data collection looks like. So I will start by giving you a short story of how this tool came. And back in 2018, we rolled out the so-called Safe Surgery 2020 initiative here in Tanzania. And this was a multi-component program that was aiming at strengthening surgical services, improving surgical systems, and changing the way surgical care is delivered. So this, the goal was to make surgery safe, affordable, and accessible here in Tanzania. And this program was made possible by the GE Foundation with lead partners, including the Assist International. And this partner was leading the innovation pillar by supporting facilities with Facility Accelerator Fund, so that they identify the gaps that they have in their infrastructure and then use that fund to to correct them. For example, other facilities built the walkway from the theater to the wards, to the surgical wards. Others were renovating their recovery rooms. Others did not have recovery rooms, so they built them. And the other thing that we supported these facilities included patient monitors, anesthesia machines with this partner. And then the other partner was undertaking the leadership and development pillar, which is somehow similar to the NODS program, because this partner was focusing at improving team structure, communication, situation monitoring, and mutual support among the team. So it also trained mentors and surgical teams to identify gaps in their facilities and seek the resources they need, taking action to improve surgical outcomes, and then share their experiences. Then the last partner in this project is the Harvard Medical School, whose role was to produce leaders in surgical systems through research, advocacy, and implementation science. So as you can see, this is a multi-component program, and we were expecting several outcomes from these facilities. One, we were expecting to lower surgical site infection rates and sepsis rate. We are also expecting to have increased surgical volume in these facilities and less surgical referrals. We are also expecting improved non-technical skills such as strengthened teamwork, communication, and data quality infrastructure, whereby these facilities would be able to make data-driven decisions. So we conducted a study and identified that some facilities performed better while others had poor performance in all these outcomes that we are looking for. So what we decided is we went back to the facilities and conducted interviews so as to learn why there was variation in performance despite having the same intervention across the facilities. So we discovered that baseline cultural characteristics, that is to say the attitudes and beliefs of the individuals in these facilities, played an important role in how these facilities could perform. So we asked ourselves, what if we could evaluate readiness of the surgical facilities prior to intervention of such quality improvement programs? And so based on the research findings and the lessons that we learned from the Safe Surgery 2020, we aimed to develop a tool that could help change agents, such as the NODS program, to assess readiness of healthcare facilities in low and middle income countries to implement safety and quality improvement interventions. So the goal here was to develop a tool that would aid others working in global initiatives, implementing effective interventions by facilitating the recognition and mitigation barriers prior to implementation. Say, for example, you ask a healthcare provider these statements and they give you these kind of responses. One, you ask them, if you make a mistake in this team, it is often held against you. And they completely agree that if they make a mistake in their team, it is often held against them. And then you ask another question, if members of this team are able to bring up problems and tough issues, and they completely agree that they disagree that members of their team are not able to bring up problems and tough issues. And then you ask them, is it safe to take a risk on your team? And they disagree that it's not safe to take a risk on their team for the patient benefit. And then you ask them another question, it is difficult to ask other members of this team for help? And they agree that it's difficult to ask other members of their team for help. If you ask them for this and they respond in that way, you will automatically discover that there's lower psychological safety within this team. So this team, the psychological safety in this team is very low, And it's a barrier that you will need to go back to the facility and mitigate it before you move on with your quality improvement project. So after learning all these, we then turned into literature on organizational change and implementation science to study the concept of readiness. And I can define readiness as simply preparedness to take future action. So after all this, we then developed a tool, and this tool is called organizational readiness tool, because it is assessing the readiness of the organizations towards implementing quality improvement program. And because this tool originated from Safe Surgery 2020 initiative, it is called Safe Surgery Organizational Readiness Tool. So in short, you may call it Organizational Readiness Tool if you want. So as I said before, we said that readiness is, we designed this tool to assess the readiness of the surgical facilities in implementing safety and quality improvement projects. This tool is still under development. So we still need evidence from the research that is going on. And mind you that you are very important to validate this tool, because the data that you will collect will help us improve and validate this tool. So if there are any changes that are needed to improve this tool, they will come from the data that you are collecting. So the ultimate goal is to make this tool freely and widely available for use, so that change agents can assess the cultural characteristics of facilities to implementation and tailor their interventions to promote success. I think I have defined readiness, and everyone can just pass through this slide and read what readiness is. But I want to emphasize that readiness is having both multidimensional and multi-level construct. Multidimensional construct means readiness is catering in all aspects, including social, psychological, contextual components. And then multi-level construct means readiness cuts across from individual level readiness to teams level readiness, and then to the facility level readiness. So when you are going to these facilities, you are going to assess readiness in a multi-dimensional and multi-level construct. So our tool has it will take about 15 minutes to administer this tool, depending on whether you administer it in person or you administer it by paper. It will most of times it will take 15 minutes. This tool has 16 domains, and in the next coming slides we will see the domains and the questions that are contained within these domains. And it's a 5-point scale tool. It's a 5-point Likert scale tool. Starting from if the respondent strongly disagree with the statement to the respondent strongly agreeing with the statement. I think you will see it in the next slides. And let's pass through these domains, briefly pass through these domains. You see there's the domains from individual level to team level and to facility level. So for example, let's see this domain called individual efficacy. This domain is measuring the individual belief that this person has the ability to perform necessary tasks successfully with respect to the proposed change. Let's say, for example, you move to the facility and you administer the tool and you read the following questions to the statements to the healthcare provider. 1, I am confident that I have the skills and knowledge to perform successfully after this change is made. And then they strongly agree with that statement, or they agree with that statement. And then the second statement, when our facility implements this change, I feel I can handle my work effectively. And then they agree, or they strongly agree with the statement. And then another statement, with training, I am confident that I will be able to perform my tasks well. And then they strongly agree or agree with the statement. Definitely, you are going to understand that this individual has a belief that has a belief that they will perform necessary tasks successfully with respect to the proposed change. So your domain of individual efficacy, there will be no need for you to go back to the facility and then find mitigations to the individual efficacy domain. But if you have respondents in this facility who are responding negatively to these statements, then you have to assess this domain. You have to go back to the facility and find the barriers. What are the barriers to this domain? And then find ways to improve that before you move on with your intervention. Same applies with the rest of these domains. These are individual level domains, and you have also team level domains. I think I described this domain when I was giving examples. This is the psychological safety domain. And then we have facility level domains, for example, leadership support, which is measuring the facility members. You are going to assess if this member has a belief that the former leaders have explicitly bought in and supported the proposed change. So there will be some questions, some statements that you will have to read on behalf of this respondent, and you have to evaluate the responses so that you come up with whether you need to go back to this facility and then look what are the barriers towards leadership support, or if the leadership support is good, then you understand that your quality improvement program is going to succeed. So these are the domains. I think you will have time to pass through them because I think you have the tool already and you have printed it. So these are the domains, you have to pass through them. This is how the Likert scale looks like. In this tool, we have two kinds of questions, and you have to read them carefully. Or when you administer this tool by paper, you will have to explain that to people so that they read them carefully before they make mistakes in responding to them. We have questions that are positively worded, and we have others which are negatively worded. For example, as you can see in these questions, these two red arrowed questions are negatively worded. For example, it's difficult to ask other members of this team for help. So if a participant gives you strongly agree that it is difficult to ask other members of this team for help, then this is a sign of a bad team. If a participant strongly agrees that if you make a mistake on their team, it is often held against them, it is a sign of a bad team. But if they respond with a 1-1 in these two questions, so it is a sign of a good team. Contrary to these items which are not arrowed, members of this team are able to bring up problems and tough issues, and it is safe to take a risk on this team. If a participant responds with a 5 in this, it is a sign of a good team. If a respondent responds with a 1 here, it is a sign of a bad team. I think everybody has understood that. So I think we are now going to talk about the sample for the Safe Surgery Organization Readiness Tool, or simply call it Organizational Readiness Tool, because it depends on what intervention are you going to assess, because this is the Organizational Readiness Tool, so it will tailor towards the intervention that you are going to assess. So because we want to understand the readiness of the facility from the individual level to the team level to facility level, we will have to get as much number of respondents as possible, and as a diverse number with different roles, so that we add diversity in the sort. So at least have a minimum of 8 to 10 participants per facility, but it depends on your facility that you are going to visit. In some other facilities, you may get up to 60 respondents, but you will have to make sure that when you sample for these respondents, get respondents with different roles. Get the nurses, get medical doctors. You have to get the leadership people in leadership positions, provided that they are exposed to the intervention that you are going to assess. So in this case, you will have to go to everyone who has been exposed to the NOTS program. Your responsibilities as a data collector include your interaction with the hospital staff. As you understand, you have to observe, you have to collect high quality and accurate data, and you should approach people diligently. I think everybody has understands that, and watch your interactions with patients, because in our African context, when you are at the health facility dressed well, everyone thinks that you can give them services. So please make sure that you provide proper interactions with the patients, and also make sure that you are following the protocol. And it's okay to make mistakes. If you make any mistake, please report that to your immediate supervisor. So what will the procedure be like? You will have at least to contact the facility and acquire facility characteristics. So in my experience, I had to contact a point person at the facility, and then I made a phone call at least 1 week before, and then at the day of 1 day before I visit that facility, I make another call. So that contact person on my end was the safe surgery focal person. So each facility had a safe surgery focal person, but when you contact that person, you will have also to contact your facility leader, because it's important that they understand that you are coming to their facility and doing this kind of project, this kind of survey. So this contact person will also help you, because the facility leaders are always busy. So this contact person will also help you get the respondents for your survey. So also make sure that you go with at the facility with the necessary documents, such as the IRB approval, and also if there is a letter from the government authorities that is allowing you to move to that facility and collect data, make sure that you are going with that document. I think I will share an Excel that has facility characteristics, or probably Shenaz has shared it with Dr. Ejid, and team will receive it. So when you are preparing for the visit, you have to print the survey and consent forms. For example, if you're expecting 10 respondents from the facility, print at least 13 forms, and so that when you get extra respondents, you don't run out of the papers. And then on my end, I was filling these responses in an Excel that we prepared, but I don't know on your end if you're going to use Excel, or if there's any software that has been developed to fill in this data, because I trained people somewhere else, and they were using a software to enter this data instead of paper-based method. So depends on what method you are going to use. If you are going to use a software, it's okay. And if you're going to use a paper, so please get your Excel ready and then enter the data on the same date and send that on daily basis to your supervisor, so that you are able to identify if there are any gaps to improve on the next day. So this one is not important. But then you have to, as you understand that you are going to interview, or you're going to meet with medical personnel, and I understand that you are also in the same field, you need to establish a rapport. You need to establish a rapport with the participants. You will have to clearly describe who you are, what is your role in the project, and then you will have to remind your participants that your interaction with them will take no longer than 15 minutes, because people are very busy, and they will not want to hear that you are going to use like 2 hours, 3 hours staying with them conducting this kind of survey. So you should also emphasize that this participation is voluntary and it's entirely confidential, so that they respond, so that you get as so that the participants become as honest as possible. And then you will have to hand over a printed survey to the participants and explain how the survey should be filled out. If you're going to administer it in a paper-based method, make sure that you revisit again before collecting this paper. You have to revisit it again and verify whether the participants have responded to all items in the survey. Because if there's they skip some responses, then it becomes unuseful. And then I know you're not going to administer this in person, so this slide might not work for you. But if you are going to administer it in person, make sure that you read the questions loudly and clearly, and then don't rush the respondents, because as I said before, there are positively worded questions and there are negatively worded questions. So if you move very fast, you may find that the respondents are responding with a 5, 5, 5, 5, and then when you move to the negatively worded question, they respond again with a 5, and then somehow it is disappointing. So you have to read loudly and then clearly so that they understand. You have to you have to be very clear to them. So at the end of the questionnaire, the respondents will fill a brief section on demographic information, including their age, their gender, their role at the facility, their time working at the facility, and this is very important. And if they have any questions about this section, remind them that their answers will not be identifiable, because there's no any place that they will fill their names. It's only their age, their gender, and their role, and how long they have been working in that role in the facility. And then after the participant is finished, fill the portion of the survey that for the data collector, and record the facility name and interview number. So for example, you know that some positions in the facilities are easily identifiable. For example, let's say a facility X called Rwanda National Hospital, and then there's only one director for that hospital, the director for the hospital. So if you have the name for Rwanda National Hospital, and at the same time the director of that hospital responded to this survey, this is kind of an identifiable data. You will have to, for example, name that facility. Instead of calling it Rwanda National Hospital, you will have, for example, call, you have a region where this hospital is found. For example, this hospital is found in Kigali. So you may name K facility number 1. So K1 as a facility, and then the respondent's ID, for example, 001. So K1 001, K1 002, K1 003, so that it's not easy that anyone seeing this data is able to identify people who responded to this survey. So I think we have explained that this data should be kept electronically into Excel, or if you have any other method of keeping it, it's okay. But in the end, you'll be able to extract it into the Excel sheet. So we have some questions that are frequently asked by the respondents. For example, we have a question, we have a statement that in the domains that is referring to training. And this statement was saying, with training, I feel comfortable. With training, I feel comfortable that I will be able to perform my duties. They may ask you, which training are you referring to? Probably you have not trained in anything. So as you understand, in our African context, when you are talking about training, people are thinking about per diems, they're thinking about personal motivation. So they will be curious to ask which training are you referring to? If you have not conducted any training, you may feel free to tell them that trainings may happen in the future. This is an ongoing project and trainings may happen in the future. And then they may ask you, what do you mean by taking risks? You may be able to explain that these are things that you may do. You may do in a way that it is breaking the hierarchy, but it's for the benefit of the patient. For example, let's say a surgeon has left a needle in the abdomen of the patient, and then a medical student is a medical student able to take a risk of asking that surgeon that, oh, please, doctor, you have left a needle there. Is it possible for a person to take such kind of a risk in the team? And also they may ask you, what do you mean by the right staff? Because this is another item that is within the tool. And you will have to explain to them that the right staff means in terms of quality and in terms of quantity. So if they feel that they have the right staff, they have to refer to both perspectives, quality and quantity. And then others will ask you, what do you mean by infrastructure? You just tell them these are the physical buildings, and then these are the physical buildings where a patient care is performed, and equipment and supplies has to do with anything that is used in care of that surgical patient. If you notice participants are answering questions very quickly, or they are answering all questions in the same manner, for example, they are picking 5, 5, 5, 5 in everything, remind them to slow their pace, and read the questions carefully if you are administering them in person. But then if you are administering them by paper, make sure that you are giving them enough time to read these questions. Facility visits should be scheduled on weekdays only. I think it also applies on your end, because you will find all the desired participants. Because when you go over the weekend, I think you may not find the leaders, for example, because you will find only those who are in the roster to work over the weekend. So you have to also provide feedback and ask questions to your research supervisors whenever you feel it's appropriate. If you have any questions that you are not able to respond, please consult your supervisors. And again, lastly, it's normal to make mistakes. Please let your research supervisor know, and you will not be punished by making or noticing any mistake, provided that you have reported it to your supervisor. Thank you. If you have any questions, concerns, please feel free to ask.
Yeah, thank you very much, Dr. Innocent, for sharing your experience with the SOT tool. Is there
Thank you
anyone who has a
for
question? Yeah, go ahead, Christoph.
thank you for a good presentation. Maybe there are some questions or suggestions that have been highlighted. We explain them during the this project implementation, especially on how we'll be doing this, delivering this data collection. Sure, yeah.
Yeah, thank you. So I had one question. Maybe we may not need to answer it now, or I don't know if you have the answer. So you mentioned that there are 16 domains, and under each domains there are a number of questions. So I was curious to know how you, like during the data analysis, or how do you score the domains? Is there like, do you calculate the average of all the questions under the domain, or how do you do that? Or you have to assess each question independently?
Yes, thank you, Dr. Ejid. We were calculating the average in each domain and then prepared a facility flashcard. So this flashcard has had all 16 domains, and then we had to give the average of each domain in that facility. So when you find that there's any domain that has a concern, then you have to address it back to that facility. I can share a sample flashcard. I think I can send you an email containing a sample flashcard for the facility.
Yeah, thank you very much. That will be helpful.
Mm-hmm.
Yeah. Yeah, so if there's no other question, we can let Christoph describe like the implementation process for this project, and maybe we can get more information about like how this project will be implemented and what we are expecting, what we are expected to do.
Okay, thank you, Ejid. And so this is as I said since the beginning, is a follow-up project on a North Coast that have been delivering a few years back. So we have delivered this course in different hospitals, but this time we have selected only 12 sites where we'll be visiting and delivering the course. And after the course, passing through the presentation you shared, we're also giving the data collection form to the participants, and then give them time to fill the data collection form. And afterwards, we would gather those data. And those data, as we said, we need a data-driven decision in regard to not course implementation, the already existing programs at different health facilities. So we do really need to have good data and accurate ones. So we then have to share the, maybe can stop sharing so that Innocent can stop sharing the PowerPoint so that I can share mine. Good, thanks. As I said, we have to visit 12 sites. These are the sites. We made the team to such way that at each site we have at least 3 people attending the site, and we will be initially we submitted the project to the ethical approval of the University of Rwanda, as we did before we delivered the North Coast 3 years back, and we have got the ethical approval. But to visit the different hospitals, we will pass through the Ministry of Health. We have written the letter to the Director of Clinical Services in the Ministry of Health, and they want to send the the invitation we've drafted, that invitation via the clinical director, the division of clinical director, Minister of Health will send the invitation to these different hospitals, mainly the 12 hospitals, so that when we visit the hospitals, they already have that information that their team from Uganda Surgical Society that will visit their facilities. So we will give it will be around 1 hour and a half training that will happen mainly in the morning, regular morning staff. We are planning to integrate this training in their regular morning staff meetings. So meaning the team that will be visiting a given hospital, like just take an example for Ruhengeri, we are planning to go there on the October 10th. So this team will go on the 9th, then pass the night there and just gather the logistics. And then the morning of the 10th, they will attend the morning, the general staff meeting. It is within that same meeting that they will deliver the training from 7:15 up to 8:30. Then after that training, they distribute the data collection form. Our data collection form will be paper-based. Will be giving the printed printouts to the participant staff, to the staff in that morning, and they fill out the data collection form. Afterwards, the team that will be on the site will later on take those data and enter them in the electronic data collection form. But we are all planning to have those the data from different sites and have be gathered at one site, and we hire someone who will be in charge of entering those data in the electronic data collection form. So we are planning to start. We got a promise that the invitation will be sent to different hospitals here this week. We are planning late Tuesday or Wednesday, but we are planning to start the exercise in Kigali at Kibagabaga, that's my working site, where we wish to invite you people who are around in Kigali to come and have like initiation of the training. Will be with the vice chair of Rwanda Surgical Society to officially open the exercise, as well as the team around which will deliver the training. But it will be also a good opportunity for people to see what went wrong, what should be improved for the next sites. It will be like a pilot site where we will be seeing how the course will be delivered. Is there anything we can follow or change for the next session? And at each team, at each site, we have a focal point, a focal person who will be contacted before we join the team. It's called like at Sehashka, we have the head of Department of Surgery, Dr. Joel. We have also Dr. Kenneth from Gynecology and Obstetrics, and Dr. Francoise from Anesthesia and the resuscitation team. So they're the ones who will be the contact person from that side. From Sashib, we have Dr. Baisenga Giste, who will be the focal person. At RMH, we have Muneza Eugene. At Kibagabaga, IB Christophe will be the focal person. At Ruhengeri, we have Hirba. And be this, see if I can scroll down. Then at Chibuye, we have Gahemba Innocent, will be the focal person. At Chibogola, we have Leonard Tobasime. At Chibungo, we have Chimimana Jackson. Rwamagana, we have Mbate, he's a gynecology obstetrician. At Byumva, we have Eric Here, and at Kabwa, you have Rene Mutezamfura. So there is a flexibility for team change where you are allocated, but this is a proposal we have drafted, and we are planning to have at each site at least 3 people. And on the coordination side, we have the registered nurse Gilbert and I, and the administrative assistant of Rwanda Surgical Society, Masi Kamukama. We will be seeing who are going at each site, and we will be the focal person to be contacted in case there is a problem, logistical problem, or whether there is any other extra support that is needed. Otherwise, we are planning to start the data collection, the project itself on this coming week, Friday, unless there's a change, but we'll be communicating along the week. But as long as we get the letter sent, invitation letter sent to these different hospitals, so we plan to start Friday at Bagabaga as initial. Then from that, maybe there are some reasons we learn and see whether we can improve. Then we work on them during the weekend, and the following week, then we go to other sites. So I will be sharing this this plan to our WhatsApp group and on emails as well. And also, as Innocent said, this data collection tool, we have it in English, but we have also translated it into Kinyarwanda so that it becomes easier and familiar with people who will be filling that data collection form. It's up to the participant to see in which language they will be good, they'll be familiar with, whether they are good, they are okay with the English or Kinyarwanda version. So, but we'll be having those 2 versions, and the staff participants will choose which language they do prefer to use for filling up the data collection form. I think this is the plan we do have, and I really invite everyone to take this project as his own, so that we really see how the data will be collecting and help us for a good decision making in regards to integration of NotCOS in our own existing programs, as we have seen that it improves not only patient care, but even the staff satisfaction, because when you are coming, your duty and everything goes well, you really you become satisfied. And of course, we also look at the patient satisfaction at large. Thank you.
Yeah, thank you very much, Dr. Christoph, for sharing the implementation plan. So once again, we thank you very much for your collaboration. So I think the NotRest program has been successful due to your collaboration and your support. And we look forward to keep collaborating so we can improve the care of patient we give to the quality of care we give to our patient. So I'd like to ask if there's anyone who has a question or comment to share with the team.
Maybe another thing I can add is that in such projects or exercise, there's a frequent asked question which is frequently asked. Will we be facilitated during this exercise? And what about the logistics? So we made the exercise drafting, we made sure people will be involved, they will be facilitated in terms of transport, and if they are even staying, they will be also facilitated in terms of the stay and also the catering. And it will be done for sites that will be visited. Yeah, I think that's something you can also share with the team.
Yeah. Thank you for sharing that information. So depending on where you will be teaching, so at some hospitals, for example, in Kigali, people will go there in the morning. So, but if you have to go, for example, to Ruhengeri or Chibogora, you have to spend the night there. So all expenses related to the training and data collection will be covered by the Rwanda Surgical Society, and all people will be involved will be compensated for their time and commitment to this project. So I think the next steps, I will share with you all the PowerPoint presentations, and Christophe will share the timeline, and also so Mercy will help us print the consent form and the data collection forms, and I think should be available everywhere we will go. So, or at least someone, either Christophe or Julie will be with the team. So in situation where when you have a question or you need more information, they will be available to help. And we have the WhatsApp group again, so feel free to ask questions there if you have any questions or need more information. So I'd like to thank everyone. So if there's another question or comment, so I'd like to invite Dr. George Nhachiruta maybe to say hi. And the Vice President of the Rwanda Surgical Society, and this project is being implemented under the Rwanda Surgical Society.
Hello, Dr. Ejid.
Hello, Dr. George.
Hello, everyone.
Hello, Dr. George.
Thank you very much. I am happy that the NOTE project is still going on. I'm sorry I joined a little bit late, but I was happy to hear that about all these projects, and I support everything about the NOTEs. If anything I can help with, please also let me know how I can be involved.
Yeah, thank you very much. We appreciate your support of this project from the beginning up to now.
Thank you so much.
Yeah, yes. So acknowledge that is Saturday evening, so I'll once again thank everyone and let you enjoy the rest of the evening, and looking forward to working with you on this project and on other projects as well. So have a wonderful evening.
Yes, bye.
Yeah.
Thank you very much.
Thank you. Bye-bye.
Bye.
Bye.